This is a presentation about a paper called A Delphi Method-Based Consensus Statement for Surgical Management of Proliferative Diabetic Retinopathy in India. So this is a recently published original article that uses the so-called Delphi method. What is Delphi method? Well, this is a method where a questionnaire is presented to a number of experts, in this case 13 vitreoretinal surgeons across India. It was a 42-point questionnaire describing various surgical scenarios in proliferative diabetic retinopathy. Scenarios that returned a moderate consensus, so not a strong consensus, in round one, were taken to a second round of questions, so a second questionnaire. This is what the Delphi methodology wants. In conclusion of the answering to these questions, a consensus was established, and something similar to PPP, or preference pattern practice, was derived. So a sort of guideline for the management of proliferative diabetic retinopathy in a real life condition, and the specific socioeconomic condition of India. Why do the authors undergo such a long study? Well, that's because surgical strategies for diabetic retinopathy management have a lot of scenarios, ranging from dense, fresh vitreous hemorrhage with no view of the retina to no vitreous hemorrhage but tractional retinal detachment. So it's a complex disease, and surgical strategies have evolved over time. And there were, in recent years, there was a tendency for early surgery for fresh vitreous hemorrhage. Moreover, despite evolving literature, controversies and knowledge gaps still exist. And I would also add that India probably has a socio-economical condition that might not really represent what is done in Western countries. So before sending the questionnaire to the previous mentioned 13 vitreoretinal surgeons, expert, the questionnaire was discussed and answered to and pilot tested by the two senior authors. So how was this questionnaire organized? Well, it was the population of proliferative diabetic retinopathy was divided into treatment naive, pre-treated with PRP or anti-VEGF, and treated previously with pars plana vitrectomy. In each of these populations, a distinction was made according to the view of the fundus, the entity of vitreous hemorrhage, the presence of traction, if no traction, extramacular or macular, and sometimes the presence of diabetic macular edema. So in the end, after answering the questionnaires, the two questionnaires, the agreement was quantified in terms of median score and interquartile range, respectively. So the median score indicates the central tendency of experts to choose a particular treatment, whereas an interquartile range of 0 indicates absolute consensus among experts. 1 and 2, on the other hand, was moderate and no consensus, respectively. In general, a strong consensus corresponded to more than 70% of experts recommending the same treatment option for the scenario. So, as we said, those scenarios that returned a moderate consensus were represented as a second questionnaire and sent to the same expert panel. This procedure was called Delphi 2. In the following slides, you can see a table representing all of the 42 questions that were sent to the experts and the results. So, returning to this scheme, we can see that in cases of treatment-naive proliferative diabetic retinopathy patients with vitreous hemorrhage and no view of the fundus, so it's impossible to perform PRP, after doing ultrasound, no traction, the consensus after the second round was to perform a pars plana vitrectomy after 4 weeks for non-clearing vitreous hemorrhage and no anti-VEGF. If there was tractional retinal detachment in the extramacular region, the time for vitrectomy shortens, still no anti-VEGF. If there was macular traction retinal detachment, well, then PPV was suggested immediately. In cases where we had some view of the fundus, then PRP had to be performed immediately. And in cases without vitreous hemorrhage and clear view, we can see that if there was no retinal detachment and no diabetic macular edema, then PRP was suggested as a monotherapy. If there was cystoid diabetic macular edema without tractional retinal detachment, then PRP plus anti-VEGF. If there was no diabetic macular edema and no tractional retinal detachment, then PRP and in cases of tractional retinal detachment, immediate surgery if the tractional retinal detachment is macular, with or without anti-VEGF, only PRP in extramacular tractional retinal detachment. So in this case is actually no diabetic macular edema and tractional retinal detachment. Then we have pre-treated patients with PRP or anti-VEGF. Similarly, in this case, after ultrasound, if we find no traction, then PPV is suggested after 4 to 6 weeks for non-clearing vitreous hemorrhage without anti-VEGF. So there's a waiting time. This time shortens in case of extramacular tractional retinal detachment to 2 to 4 weeks. Again, no anti-VEGF. Whereas in cases of tractional retinal detachment involving the macular area, PPV was suggested immediately. In cases without vitreous hemorrhage, it's observation if the macula is not involved, whereas it's PPV immediately if the macula are involved, and also if the retinal detachment is combined tractional and rhegmatogenous. In this case, in the second round, silicone oil tamponade was the best choice. In patients with PDR that underwent already PPV, treatment depends on the vitreous hemorrhage, according to the fact that it might be first vitreous hemorrhage or recurrent vitreous hemorrhage. So it's observation if it's the first, it's recurrent. If it's recurrent, the PPV must be repeated with lavage of the vitreous chamber. In cases of neovascularization on the iris or neovascular glaucoma, anti-VEGF is recommended. So some of these results are important because literature is unclear, for example, on the approach to macular tractional retinal detachment according to the timing. So there's no meaningful evidence favoring early over delayed surgery. Whereas in this study, there was a consensus of early surgery. In other cases, like in this example, in a review article by Stewart, there's a overlap in guideline between this Delphi study and the review article by Stewart in saying that for macular involving tractional retinal detachment, surgery is recommended. Other considerations were that a strong consensus on USIS 25G vitrectomy systems was achieved. The 13 experts from the Delphi study recommended temporary discontinuation of antiplatelet drugs. Bimanual surgery was preferred by 50% of participants, and a strong consensus was achieved in recommending against routine ILM peeling in diabetic vitrectomies without ERM or macular pucker. So again, Delphi method-based studies are important because give a picture of the real-life management of cases. So most experts in the panel felt the need to stop antiplatelet agents before surgery to minimize intraoperative bleeding, despite recent papers showing no association between antiplatelet agents and vitreoretinal surgery. In this case, translational research explains actually why the surgeons decided not to peel in every case the ILM. So this is an example of how basic science translates into surgical management. In conclusion, This expert panel recommends early vitrectomy at around 4 weeks for non-clearing vitreous hemorrhage in eyes with proliferative diabetic retinopathy, titrating waiting times to slightly shorter with more tractional elements and longer for pre-treated eyes. Immediate surgery is recommended for eyes with macular tractional retinal detachment, irrespective of other circumstances at play, though the use of preoperative anti-VEGF is recommended only in cases with large membranes requiring extensive dissection. The recommendation for extramacular tractional retinal detachments is to wait and watch until there is vision drop and surgery becomes mandatory. In vitrectomized eyes, the first episode of vitreous hemorrhage should be managed conservatively, while recurrent vitreous hemorrhage may require immediate surgery. In presence of iris neovascularization, immediate anti-VEGF followed by early vitreous lavage is recommended. Surgeons should operate on the eye with better visual potential first in cases requiring bilateral surgery. Thank you.